I hope you can hear me, see me, and look at my slides as well. So the first talk is to look into the tips and tricks of transcatheter mitral replacement. And one question, of course, is why do we need transcatheter mitral replacement? We're doing such a good job with TEER in the mitral space, or are we really doing it? If our target is to eliminate the MR, we clearly are not there yet. We're very efficient with the latest generation iteration of the two devices of TEER, both MitraClip and Pascal, and more devices are coming. But clearly, the option of having a replacement that potentially could offer a more standardized way to treat MR with somewhat less unpredictability and less operator dependence is very, very appealing. And, we always have the TAVR as a paradigm to follow. And clearly, it's what the industry wants and potentially will benefit our patient. But is it easy? Clearly, we've done this with prosthetic mitral valves in place. This is one of our cases with severe stenosis. And the tip here is to have a very clear evaluation of the space in the LVOT and also some idea of the trajectory and the angle of attack going through the septum, because the preferable way here is to go transeptally and implant a balloon expandable valve into this previously implanted surgical valve. So quite reliably in this situation, we can measure the neo-LVOT. So by putting the new valve in there and pushing out the leaflets of the surgical valve, we create a cover stent. So effectively, the neo-LVOT that is left should be enough. And what is enough? Anything above 180, 200 ideally square millimeters would be enough. And here is 350. So it's quite easy in most of the situations to inflate a balloon expandable valve. This is a MIVAL with a fast pacing and have a very good result that can be assessed on the TEE and also hemodynamically. Of course, we can do that with valve in ring. There we need to assess the projected neo-LVOT, but also have an idea of the length of the anterior leaflet. Various lengths have been proposed, anything above 25 millimeters at the A2, but maybe lower, 23 or even 20. This particular case had a 20, and we elected to do a lampoon, so you can see the flying V on the left, lacerating the middle of the anterior leaflet, and then inflating valve in ring. And then you can see the result with the LVOT being widely open. And of course, we have the MAC, and the MAC is a problem for surgeons, is a problem for transcatheter, is a problem for TEER. And here is a very difficult case with a septal bulge and the elimination of the LVOT. The neo-LVOT here was 80 square millimeters. However, the skirt neo-LVOT, so the projected neo-LVOT space that would be left between the intraventricular septum and the skirt of the balloon expandable valve was adequate, was 185. So we elected in this case to perforate the anterior leaflet. This is a Batman case by using a steerable guide and the back end of an 035 electrified wire. You can see the electrification here. And by implanting inserting two wires and dilating with an Atlas 14 millimeter balloon, you can see how tough the leaflet is, perforating. We were then able to deploy a balloon expandable valve with a very good result and no LVOT obstruction. So always look at the LVOT, always look at the length of the anterior leaflet when we're talking about native, always assess the max circumference. But this is when we use balloon expandable prosthesis in the mitral space. This is a result of this patient, and this is the transthoracic echo on discharge. What about dedicated TMVR devices? It has been a long journey that started in 2012 and failed badly, many $1 million later. And out of this first generation, only 3 devices are alive, and with several modifications. Actually, Tendyne is still alive. And, about a year ago, we were talking that Tendyne would be dead because it's transapical and clearly the way is transfemoral. But actually, Tendyne is here and just completed the MAC arm. The enemy here again is LVOT, the presence of MAC, and also the size of the annulus. Also the approach, whether it's transfemoral, transapical, the size, and of course, clinical factors. These patients tend to be sicker than the TEER patients. But new kits are coming on the block: AltaValve, M3, Evox, Ephia. You see the names. What is actually happening? And Summit trial has finished the MAC arm and had Tendyne now has a FDA only recently for the MAC. So actually still alive and still available, actually available in Europe, but also available in the US now. And the Encircle trial is ongoing, but the M3 now has got CE mark in Europe. And this is a device that has a docking system that is hydrophilic and wraps around the cords in the ventricle, creating the dock in order to inflate practically an S3 fully covered valve, the M3 valve. So it's like putting a valve in ring, but you have first to put the ring in there. But the Encircle trial has finished, and now we're waiting eagerly to look at the results of this trial. CE mark is obtained, however. And the Intrepid is alive, and now the Apollo EU and the Apollo US trial are ongoing with a new iteration 29 French system with a 54 millimeter. Actually, now more patients are being recruited as we had the refinement of these devices. The tips and tricks here are absolutely device dependent. So you have different tips and tricks if you go transapically, different if you go transfemorally, different requirements for the dock of the M3, different requirements for the Intrepid cohort. And we have AltaValve that I'm going to show you in the live case, which we started, what is the new iteration, the 29 French. This is out of the box device. This is atrially fixated, and you can see the tilt anteriorly, leaving a widely open LVOT. So for AltaValve, LVOT is not a big problem. The sizing here is mainly done on the annulus and the left atrium. So we're looking at left atrial height and width and also volumetric changes during the cardiac cycle in order to accommodate this device. But these three devices, Encircle, Intrepid, M3 finished, Intrepid, and AltaValve are currently in the pivotal state. So clearly we'll be looking out this space for this. InnoValve is a new kit on the block acquired by Edwards. Certainly a very interesting device. Of course, MAC and cords that are thickened are excluded, but patients with functional MR are probably an ideal target. And if you twist the cords, then you can deploy the flange and the device. So thus potentially remodeling the left ventricle. So different population to target on the InnoValve will see this space. So the tips clearly are device specific. It's a bigger intervention, bigger footprint device, greater disruption of the native anatomy, and afterload mismatch of the LVOS reality. So the main tip is actually manage the patients pre-procedurally, peri-procedurally, and post-procedurally is a big deal, is not the same as TEER, and preload considerations may be particularly important specific to the device. For example, AltaValve does not require big volume changes prior to the procedure because the LA may shift. And also always keep an eye on LVOT obstruction, may be not anatomical, but dynamic, particularly if the patient is dehydrated. Of course, another aspect that comes into play is the management of iatrogenic ASD. The flow can be left to right, bidirectional or right to left, and it'll have to be carefully evaluated for each patient. And last but not least are the anticoagulation concerns. We don't have them in here. Similar to TMVR, the bridging and the choice of pharmacological agents are very important. Thank you very much for your attention.
Thank you, Vlasi. That was a fast and very succinct review. Yeah, this is a very difficult field, and from the three valves that are currently still going on, which one do you think, I know it's a difficult question, but which one do you think has more potential?
I think ultimately it's going to be a toolbox approach. M3 clearly wraps around the cords, and in some subset of patients that may be beneficial, maybe some remodeling there. But again, LVOT is an issue, despite of gathering the anterior leaflet. Intrepid for a long time has been a lost cause, but perseverance and engineering refinement actually makes it a little bit more promising now. So I see now that the acceptance rate is up to 40% in the current iteration, whereas before it was less than 30%. Alta valve clearly has got the biggest potential when it comes to LVOT. In the EFS, about 70% of patients were eligible anatomically. But of course, we have the left atrial issues, like you have to have certain sizes. Too big left atria are excluded. And I would be looking out the space for InnoValve, particularly as LV remodeling is a possibility. That might be quite attractive for secondary MR with big LVs. We'll see.
Great, thank you.
I cannot give an answer, obviously.
Well, it's as good as it gets, your answer.
Vlasi, thank you for your great survey upon the incoming technology, and it's very, very timely for me. Since this is a conference reaching live cases, I'm going to have to ask you a question now. I was recently referred a 73, 74-year-old lady, NIHA 3, allow me to say 3.5, eventually. And she's been sitting on a mitral valve stenosis with a semi-circumferential asymmetric calcium buildup on the posterior annulus mainly. Didn't want to be operated, now she wants to be operated. She's with the back against the wall. Problem is that she has a pulmonary hypertension recently measured on right heart cath, 110. While she was lying on the cath table, the systemic was 100. She did manage to finish her spirometry study. The FEV1 is around 45 to 50%. Right side remarkably contracts well. The ejection fraction is on the left side is 60, 65, normal. And the family, very educated, they all push for solution. Number one, surgery with a calculated Euroscore yesterday of 36.5 on my computer, which underestimates the risk. Any other options from your side? Or eventually a hybrid procedure together?
Lovely case, huh?
This is what I get.
Well, if we exclude surgery, the options are balloon valvuloplasty, and other anecdotal cases with lithotripsy with shockwave balloons that they've been used to soften up the tips of the leaflets and use that as a bridge to something, either surgery by reducing the risk, reducing the pulmonary hypertension. Most of the dedicated devices are not used for mitral stenosis. I know AltaValve is now altering the protocol, incorporating in the pivotal trial moderate MS and moderate MR, but not isolated severe MS. And of course, you always have the option of a balloon expandable valve in there, but we have to see the distribution of MAC, the LVOT, all this that I discussed. Unfortunately, what I do see, because we also get patients like that, is the mitral stenosis currently is the Achilles heel of transcatheter intervention. For MR, you can do stuff, but for MS, it's kind of difficult. I don't know if Dr. Pavlides or any other in the room has got a different opinion, but it's a definite solution when it comes to stenosis. I find it very difficult to provide.
Well, the current stenosis, which is mostly a calcified valve and an annulus, yeah, that's a major issue. It's a very different animal from the old days rheumatic stenosis that could be treated by valvuloplasty. So you're correct. This is a difficult problem to solve. I don't have any solution either. We have three panelists. Dr. Lerakis is online, and Dr. Ninios and Dr. Dimitriadis in the room. Any comments? No, I don't see anything. Anything more?
Well, it's nice. Thank you, Vlasi. I may as well send you some of the images and, share thoughts.
Let's discuss.
Yeah.
Thank you, Vlasis.